Thank you, Giorgio. Thank you, Luis. It's a pleasure. Good morning. I like the fact that you have joined primary prevention with the early detection, because today early detection is very fashionable and the screening is very fashionable. But we have to consider, the efficacy of every option and their possible combination. So it's good. The decline in lung cancer mortality in the United States and Europe has been constant from the 70s, 80s, and is 20 years after a parallel decline in tobacco consumption. So I don't see the reason why this curve should not go back to zero. But unfortunately, in most countries, we have stopped prevention measure when we reach that hard socket of 20% of current smoker, which seems to be a level that cannot be cut. I disagree. I think strategies should go forward, and we have now more chances to win this battle, and there is no way to win the lung cancer battle if you don't go down with the proportion of smokers. So we should not accept 20%, and we should not accept that female continue to smoke more and more. In my young daughter's class, she's 16, she's the only one that doesn't smoke among females. And to me, this is a disgrace, and we should not accept this as a common rule, as something inevitable. So we should fight for tobacco control. Lung cancer cure has improved. It's a EUROCARE registry data, so population-based, and certainly there's no doubt that the proportion of a survivor at 5 years has increased from 8 to 13% in Europe on average, but 13% remains 13%. 15 years of screening have proved that low-dose CT can detect early lung cancer, on average about 1% of each individual that undergo low-dose CT screen have a lung cancer at baseline, and about 60, 70%, even 80% sometimes, have a stage 1 disease. The problem is that only 1 in 20-25 positive LDCTs are cancer. So there is a huge problem of false positives. The NLST trial is a landmark, you all know, and it proved that 3 courses of LDCT can reduce specific and overall mortality. But the real extent of this benefit, if you measure with a normal curve, 0 to 100, is small. You see, is a minus 1% per year reduction of total mortality, and the 2 curves are almost superimposed if you don't squeeze them by using different ranges. And even in a recent pooled analysis of 2 European trials showed the same, 1% reduction per year. And this, given the numbers, it does not reach statistical significance. But I'm pretty sure that the pooled analysis of a European trial, and probably also the Nelson, the largest European trial, will show a similar benefit. How can we improve the performance of CT? First of all, the easiest thing is to increase the cutoff size. So 5 millimeter diameter is no good. 4 millimeter diameter is even worse. Probably if you take 6 millimeter diameter, you get much better performance and you lose almost nil. But as the Nelson trial showed, volume is the good cutoff, the good way to measure and to decide what is suspicious. And cutoff is also, volume is very important to assess growth. It is impossible to assess growth if you use diameter. Unfortunately, the LST trial and most of your American studies continue to use diameter, but diameter is not a way to assess suspicious lesions. Of interest, all randomized European trials use volumetric assessment, and I think this will improve the performance. And different trials reached the same conclusion. For example, the Nelson study started in 2005 with a very wide range, 50 to 500 square millimeters, to get to a recent update of the analysis where the cutoff was narrowed to 100, between 100 and 300. And this is the same thing that happened in our experience. In the new biomill, we have a range of 110 to 250 as a cutoff. The new evolution makes computer automated reading of the CT with the technician as the first leader, makes the whole thing easier and much cheaper. So the future will be radiologists being involved only in a second level assessment of a tiny proportion of the LDCT, while most of the CT will be automatically managed by computer, by CAD and by a technician. Of course, we expect from the improvement of technology something more, and this ultra-low CT is already showing that you can get much better view with much less radiation doses. But is size and volume time enough? Well, we don't think so, because the proportion of individual having a surgical biopsy for benign disease is much higher when you only use volume time compared to PET and volume time, as we do. And we are now far below 5% of surgical biopsies for benign disease compared to the average 25-30% in the trial that don't use PET. How often you should screen? We have published this year a randomized study showing that doing LDCT every other year gets the same yield of a yearly CT. So probably it's unnecessary to do yearly, as long as you do it for a long period of time. The minimally invasive approach is an obvious consequence of early detection. So the earlier you detect, the better you can handle with a non-invasive surgery. But is a robot really a breakthrough? This is still a debatable thing. I mean, there are advantages in the robot, but the new 3D VATs get the benefit of a much simpler and much less expensive procedure with all the advantages of the robot. So we have used this in the last 3 years, and we have very good performance. So over 75% lobectomy in VATs for CT detected lung cancer. Subsolid lesions are important problems to avoid useless surgery and avoid over-treatment of non-evolving lesions. This is a common experience of Japanese and European and American groups, although the Japanese tend to implement the early resection of subsolid lesion in a way that does not seem to be necessary. And so we have implemented in the middle trial the active surveillance approach to subsolid lesions from the very beginning, from 2005, and we had already a report in 2012 showing that this is feasible. We are now ready to publish the 10-year results of active surveillance that shows that indeed a few of these lesions evolve into invasive cancer, but it is only a tiny minority, 1%. But what is more important, many more develop invasive cancer outside, in a different position, in a different place. And having resected this non-evolving lesion may compromise the chances of doing a proper surgery for the invasive disease when it happens. And so active surveillance is safe and effective. But what is more important, in my view, is that screening offers a phenomenal possibility to study the biology of lung cancer. So translational research in low-dose CT trials is probably going to become one of the most important revenue of the screening experience. Just as to mention, we have now about 8,000 individuals, but these 8,000 individuals under screening have generated over 100,000 samples of both blood and the tissues, and this is enabling us to develop biomarker assessment and biomarker research. Today there are different approaches, of course. So there is basically, there is studies on the oncoimmune, using the oncoimmune approach, looking at cancer antibodies in the blood. There are proteomics, but the proteomic is still not applicable in large-scale trials. And there is the microRNA. We have opted for microRNA 10 years ago, and the microRNA is interested because it is not essentially focusing on cancer products or particle of cancer. MicroRNA is generated, as you see, by every cell in every compartment of the body. Is not related to cancer. These are just regulator of growth. And what is important in a cancer patient or a high-risk individual is that it gives you an idea of the microenvironment, not just of the cancer. So it can be detected when the cancer is too small to release sizable amounts of DNA or particle in the blood. But still, the microenvironment can be used to achieve early detection. There are many. We started with 400. Most of the groups ended up with 20. We have now 24 microRNA. And we showed that this is very promising in terms of detection, because it can reduce the number of false positive CTs. And so combining microRNA in the blood with the CT, you can have a much better performance. Obviously, the question is, can you anticipate the diagnosis or at least the definition of a high-risk individual of a few years, and thereby improving the chances of managing this? This is the question of the future. We have a prospective trial of 4,000 individuals going on, and we will probably deliver a final answer on the real efficacy of the blood test by the end of 2018, so in 2 years' time. So in summary, there is a good prospect for screening as long as you get a better target of high-risk individual, and you improve not only the selection of individuals that should go under screening, but also improve the diagnostic algorithm, and you implement with biomarkers. But in terms of efficacy, the most important approach is to combine early detection with the primary prevention. And this is because lung cancer only kills a small portion of heavy smokers, of lifelong smokers. As you see, in current smokers, 20% die of lung cancer. In former smokers, 10%. So this approach cannot modify the chances of surviving in high-risk individuals. We have, on the other way, we have very large studies. I only quoted these two, but 1.5 million individuals, showing that quitting after the age of 50 reduces significantly the mortality. Even after 30, 40 years of smoking, if you quit, you cut your chances of dying. Unfortunately, NLST trial did not approach this problem, even in terms, at least in terms of monitoring the smoking habit during the screening. So they are unable to tell who has quit during the screening. And they have refused to publish the separate data of the half of the individual that already quit at the time of randomization, which is, to me, a nonsense, because there's, it's very easy to say what happens to the screening if you look at those who continue to smoke and those who don't. In a recent paper, they have admitted that the quitter had a much lesser mortality. In our experience, we have demonstrated, and this published on JTO last year, that quitting not only before the screening, but also after the randomization into the trial causes a significant reduction of mortality. So even a late quitter have a lower risk of dying. So there is a big opportunity, and it is not very expensive. This is a recent presentation of Bill Evans from Canada, showing that adding smoking cessation to screening only costs a tiny amount of money. And if 50% of the individual enrolled in a screening would stop only 50%, that would cut by 50% the overall cost in terms of quality of life, years of a good quality of life. But there are other aspects that are, surfacing from the screening experience. For example, inflammation, which is very easy to measure by a simple test like C-reactive protein, is related to mortality not only in lung cancer, but also in COPD. And this is a very consistent evidence. From the MILDA trial, we are going to publish this in the European Journal soon, that combining high CRP level with the poor lung function, you can define a subset of a heavy smoker with a much higher chances of dying. And this has not only an importance in terms of defining high-risk individuals, but it is important because CRP levels and the inflammatory status is modifiable. It is modifiable by simple drugs such as metformin or statins. It has been already proved that you can decrease the level of CRP by both metformin and statins, probably with aspirin as well. Of course, we cannot tell that by doing so you can reduce mortality, but it's worth trying. And of course, there are other elements of risk that could be modified, and this is diet and it is physical exercise. As a physician, you should all be interested in considering that every patient that you see that is a current smoker can be helped with a simple drug such as varenicline. The chances that it quits smoking are around 50%. So varenicline should be part of the therapeutic armamentarium. I'm going to close with this, showing you the design of this study that we are hopefully starting this year. That will be the first study combining early detection and active intervention using drugs, diet, and physical exercise in a population that not only is at risk because of smoking and age, like the NLST criteria, but because they have elevated CRP at baseline. We think that this is an opportunity to demonstrate to what extent pharmacological intervention, in this case by varenicline and aspirin, modification of the diet and physical exercise, is an option that can be applied to high-risk individuals together with early detection. We have to consider that sustainable healthcare in an aging population cannot include targeted therapy for metastatic lung cancer. for all metastatic lung cancer. This is unsustainable. And if you add anti-metastatic to anti-BPCO with the new biological, the cost would be enormous. So we need preventive strategies. So my take-home message is if we want to get what has been achieved in cardiovascular, so a huge drop of mortality while in cancer we achieved a tiny reduction of mortality, we have to include, prevention measure. And stopping smoking is not only feasible with the new drugs, but is very useful even in individual after the age of 50. And of course, we need other preventive strategies in those who quit, because quitting smoking does not reduce the risk of cancer for many years. So we need to modify the inflammatory, metabolic, and immune profile. One of the links between the recent immunologic knowledge and all that, the enthusiasm for immunotherapy can be applied to prevention as well. Because we already know that chronic inflammation is affecting immunity. And probably one of the mechanisms by which high CRP increases mortality for all diseases, not only cancer, is immune suppression. So all the research that we are developing today, on immunotherapy of metastatic cancer should be expanded to, modification of the immune profile, of the inflammatory profile. They can get a new approach to chemoprevention. So chemoprevention of the future is related to immunotherapy, and it will be, in my view, immune prevention. And of course, stopping smoking is essential. It is part of it. Thank you.